We already have a few people on, but we will give it a few minutes after, and then we'll get started. And just so everybody knows, this meeting is being recorded, but we cannot see anyone besides Dr. O and myself, and we cannot hear anyone. If you have any questions, then you can put them in the chat, and we'll ask them at the end. Dr. O, I tried to convince a lot of my female friends to have their partners come on here because usually men rely on their partners for their health appointments and all that good stuff.
Yeah. Um, Usually women are better at thinking of their preventive health care, but everyone it's important for everyone.
Oh, good. Karen's husband is sitting next to her right now.
Mhm.
Excellent. Thank you, Karen. I'll give it a few more minutes. And this is being recorded. It will definitely be on the Palcus website. I also like to share it to social media. Um, Last month, a lot of people asked me for the recording because they couldn't make the time. It was a difficult time for many people, 5 o'clock. So thank you for accommodating this 6 o'clock start. I think it's a little bit better. Okay, I think we can get started. Is that okay with you, Dr. O?
Sounds good, Susie.
Okay, great. All right, so my name is Susie Ferreira, and I'm a clinical research nurse with the Yale Clinical Trials Office. I work in conjunction with the Smilow Cancer Centers in both Greenwich and Long Ridge. I am also a healthcare committee member with PALCUS, and PALCUS is bringing this webinar to you today. They are the host. If you are not familiar with PALCUS, we are the Portuguese American Leadership Council of the United States. We're a national nonprofit organization focused on strengthening the Portuguese American community through leadership, advocacy, education, and cultural connection. Our mission is to bring people together, amplify our community's voice, and create opportunities for engagement across the country. We're delighted to host this conversation and to have you join us today. And today we have Dr. William O., who works with me at the Greenwich Clinical Trials Office and Smilow Cancer Center. He will be talking about prostate cancer and trends in 2026 and beyond. He will review trends in epidemiology, PSA screening, and treatment advances. And I'd like to read a little bit about his biography. Dr. William O. is the Director of Precision Medicine for Yale Cancer Center and Smilow Cancer Hospital, as well as the Jean and David Wallace Medical Director of Smilow Cancer Hospital at Greenwich Hospital. He is a professor of internal medicine in the section of medical oncology and hematology. At Greenwich Hospital, Dr. O will continue to develop integrated oncology care teams and expand the impact of multidisciplinary cancer care for patients in the region. In addition, as Director of Precision Medicine, he focuses on building a cohesive program in precision medicine, integrating basic and translational science, clinical trials, and Smilow Cancer Hospital's Precision Medicine Tumor Board. He is committed to increasing the routine use of molecular and genetic testing for all patients with cancer, a goal he has been committed to throughout his career. Dr. O is a genitourinary oncologist with decades of experience caring for patients with prostate cancer. Before his appointment to Yale, Dr. O served as the Chief Medical Officer and Executive Vice President of the Prostate Cancer Foundation, where he focused on barriers to the delivery of care for prostate cancer nationally. He also served as Chief Medical Officer for Semaphore, where we met, a patient-centered health intelligence agency. For over a decade, Dr. O was Chief of Hematology and Medical Oncology, Deputy Director of the NCI designated Tisch Cancer Center, and the Ezra Greenspan, MD, Professor of Clinical Cancer Therapeutics at Icahn School of Medicine at Mount Sinai. He began his professional career at Dana-Farber Cancer Institute and Harvard Medical School, including roles as clinical director of the Lank Center for Genitourinary Oncology and director of the Gelb Center for Translational Medicine. I'm almost done. Dr. O completed his undergraduate degree at Yale University. He received his medical degree from NYU School of Medicine and did his internship and residency at Brigham and Women's Hospital before his clinical fellowship in medical oncology at Dana-Farber Cancer Institute. Dr. O currently serves as chair of the American Cancer Society's National Prostate Cancer Roundtable, whose mission it is to improve prostate cancer outcomes and survivorship through increasing awareness and equitable access to prevention, screening, and treatment. Also, he is the chair of the Medical Advisory Council for the Chemotherapy Foundation. It's a 55-year-old organization committed to discovering novel therapies for cancer. And that is a mouthful, and I am so happy to bring to you Dr. O, and I'm going to let him take over the screen. Thank you for being with us tonight. It's a great month because it's Men's Health Month, and it's Father's Day around the corner. And it's all yours, Dr. O.
Thank you, Susie. Thank you for, sorry for that long introduction, but thank you for having me speak to your organization. And it's really wonderful to be able to do a focused talk on a disease, as you heard, that I've been really focused on for much of my career. And what I wanted to do in the next 30, 40 minutes is give you an update on prostate cancer, what's going on in this space, and where the field is heading. Let me just see if I can make this. Oh, there it is. I'm going to start with a patient case. This is an 82-year-old white male who presented with a prostate nodule on exam. That means that he had a digital rectal exam, a prostate exam, and his doctor felt a nodule. He had actually had PSA tests until he was 71. Now he's 82, but basically he stopped at the age of 71. And he has several chronic medical conditions. You may recognize some of these, things like atrial fibrillation or acid reflux disease, high lipids, and seasonal allergies. Nocturia means he was waking up 1 to 2 times a night, not uncommon in an 82-year-old man. And his PSA, since it hadn't been done in a long time, is now 17.2. And his prostate exam, his digital rectal exam, showed a firm nodule on the right side. So he does get a biopsy, and he has a Gleason 4+5 cancer. We'll talk a little bit about what this means, but this is a high-grade cancer, an aggressive cancer. He gets an MRI, which shows this nodule and the cancer is breaking out of the prostate. But more importantly, he does a PSMA PET scan, and it shows multiple bone lesions. You can see some of these on this scan. It should be, clean on, for example, in the arms. You can see the kidneys, that's normal, but you can see all these little spotted marks. Now, this is not a real photograph, but this is President Biden's story. So as much as I can tell from what's been publicly assessed, my understanding is that former President Biden, does not have this many spots on his bones, but some of this was actually true about him. He had stopped PSA screening. He had some chronic medical issues. They never published his actual PSA, but this is actually his Gleason score. So, how does the former president of the United States get metastatic prostate cancer? Kind of the most powerful man in the world, really, and yet his cancer was able to not only show up but also spread throughout his bones. So, I'm going to talk a little bit about five areas. And again, I realize this is not intended to be focused to doctors, but really to patients and to average men and their families and their loved ones. But I think these are all relevant statistics and facts. So let me talk about the five facts about prostate cancer tonight. The first, the incidence is rising, especially of metastatic disease. Well, what does that mean? Every year, the American Cancer Society publishes statistics, cancer facts and figures, and you can see that prostate cancer is the number one cancer in men in the United States. And it's actually the second leading cause of cancer death in the United States in men. These numbers are similar across Europe, and in fact, in Portugal, it's also the number one cause of cancer in men, and it's the third leading cause of cancer death. The problem is that these statistics are not getting better; they're getting worse. There's a change in the incidence, and what incidence means is the number of new cases. And you can see here that if you go back here to this spike in the 1990s, this spike really came about because the PSA test first became available. And you can see that before that, it was fairly common, even before PSA testing, but there was this big spike, and then it kind of leveled off because everyone who had prostate cancer, we kind of found it. And then for some reason, it started to drop. The incidence started to drop, but then in the last decade, the incidence has really spiked, and you can actually see a similar spike in breast cancer in women. Even as lung cancer and colon cancer have incidence rates have gone way down. Lung cancer because men stopped smoking, in the 1960s and 70s, and you can see it takes a while before that impact shows up in the risk of lung cancer. But this bump is quite concerning. People don't really understand, but it may have to do with the fact that PSA screening rates have actually gone down over the last few years. The other thing that we see, and this is if you look at this curve, it goes to the 1970s. That's when the U.S. government started tracking the prostate cancer incidence rates, but they've actually been tracking death rates even farther, all the way to the 1930s. And you can see some interesting trends here, similar to the one I just showed you. Like lung cancer death rates have gone down in men. This is just for men. And why? Because, of course, men stopped smoking in the 1960s and 70s, as I mentioned. And not only do they have less lung cancer, but they're dying less of lung cancer because they're less likely to have it, and it's being caught more earlier. But prostate cancer, you can see, is still the second leading cause of cancer death in men. And it has also gone down a little bit. But if you notice, it's starting to plateau here. Unlike lung cancer, which is still going down, why is prostate cancer death rate plateauing? And one theory is that maybe it's because we're doing less PSA screening. And this is the Lancet Commission did a report in 2024, which looked at worldwide risk of developing prostate cancer and of dying of prostate cancer. And you can see here in blue is the 2020 rates of prostate cancer, and in blue plus red is the 2040. So in 20 years, you can see that in East Asia, the incidence and the death rate from prostate cancer is going way up, probably because of dietary changes, maybe lifestyle changes. It's a little unclear. You can see in Europe, if you look at Western Europe, it's already still a pretty common cause of cancer, and it's still a common cause of cancer death. But there's less cancer death in Western Europe because the treatments are so good for it relative to, let's say, a place like South America or Southeast Asia. You can see the death rates are higher in countries that probably have less good health care, like, Southeast Asia or South America, and even East Asia, where the death rates are projected to go up quite a lot in the next 20 years. And in fact, again, if you look down here, the total number of deaths are projected to go up by 85%. So unfortunately, this is not a disease that's going away. It's a disease that continues to have a significant impact. What are some of the risk factors for prostate cancer? Well, the chance of getting prostate cancer, you can see here that if you're a young man, you're very unlikely. This is a disease of aging, and as you get into your 50s, 60s, 70s, you can see the incidence rates start to go up. This is the rate per 100,000. And what they do in this graph is they break it down by your race. So if you look at non-Hispanic whites, which is what Portuguese American men would be categorized as, there are these circles here, and you can see they're the second highest incidence as you look at this graph. The highest incidence is black men, and you can see that black men have the highest incidence of prostate cancer, and it goes up in both groups as you get older. You see the peak is kind of in the 70s, 60s and 70s, and it starts to taper off as you get into your 80s. If you look at another group like Asian men, you can see that they have a lower incidence, but it's also driven by age. Now, one thing that you hear a lot is if you get older, you never die of prostate cancer, and that's actually not true. Really, one reason it starts to taper is if you make it into your 80s or 90s, you don't die of other things. You don't die of heart disease, you don't die of strokes. So people who don't have other medical problems, if you have prostate cancer, over time, what really happens is that the prostate cancer becomes an increasing a threat to you if you actually have it. So the way you look at this is that this is the risk of dying of cancer by three age groups, 50 to 64, 65 to 84, and over 85. And if you look in the older men, prostate cancer is the leading cause of cancer death, more so than lung cancer. This includes men and women, more so than breast cancer or colon cancer. So how could that be? Well, because if you're diagnosed in your 50s or 60s, you may get treatment, but you're less likely to die of it. If you don't cure it, eventually this cancer can become more of a problem. So the whole point of this slide is to say, just because you're older doesn't mean it's not a risk to you. And that is, every day I'm in clinic, I'm always seeing men, even sometimes in their 70s or 80s, where we're trying to make sure that the kind of cancer they have is not one that will be dangerous or kill them. And this is particularly important for somebody like President Biden, who's 82, but otherwise pretty healthy. But we know he may have some other medical issues. How do we treat him so that this doesn't happen to him as he gets into his late 80s or early 90s? Okay, let's talk about PSA screening because, of course, this is quite controversial. And what I say here is that the screening guidelines are evolving. Well, what is PSA? First of all, this is what PSA looks like. PSA stands for prostate-specific antigen. It's a protein that's secreted by your prostate gland. One thing about the prostate gland, which is a small organ that sits right under your bladder and right in front of your rectum, is that we don't really know what it does. It's probably important for fertility. So if you didn't have a prostate and PSA, you probably wouldn't be able to father children. But this is an enzyme that kind of makes your semen able to impregnate an egg and thus allow you to become a father. Other than that, as you get older, the prostate and PSA really, it's not clear that it has any value, but normally it's present in low levels. So this was the first paper, and you can see in 1987, when I graduated from college, this is when this paper first showed that PSA could be a marker for cancer of the prostate. But you have to go all the way back to 1979. That's when they first realized that PSA could actually help to detect prostate cancer at all. So what causes elevations in PSA? Well, the problem with PSA is it's not a cancer-specific marker. PSA stands for prostate-specific antigen, but it's not prostate cancer-specific. So you can see that an enlarged prostate can elevate your PSA. Inflammation of your prostate can cause it. Of course, cancer is the one that we worry about. If you ejaculate within 72 hours, that can also elevate your PSA. A very rigorous prostate exam can do it, but riding a bicycle can do it. And this study was interesting because this is about a 20-year-old study, almost 25, which showed that if you just biopsy all men This was a study where they didn't do anything to the men except biopsy them 7 years after they were on a placebo. If you just biopsied them all, you can see that even when your PSA was under 4, 4 is considered a normal level of PSA, you still had up to 10% of the men actually had high-grade prostate cancer. That's an aggressive prostate cancer. And actually up to 40% of the men had some cancer in their prostates. So by itself, there's no such thing as a normal cutoff for PSA. And a lot of times, a key to PSA is kind of understanding what the trends with PSA are. So we do know that we can see year-to-year fluctuations in PSA. So this is a paper that basically showed an average man, their PSA is kind of going up and down. And if your PSA was over 2.5, there was a 40% chance that that PSA would go back down to normal, under 2.5. And if you use 4 as a cutoff, there was a 44% chance that a single rise might actually go back to normal in a subsequent test. So what's the message of this? Well, a single PSA by itself doesn't mean that it's dangerous or that you have cancer. You always have to repeat the PSA, and that's because the PSA may not reflect real cancer. There are markers that doctors have used, and there's actually a growing number of these markers. Like, for example, the younger you are, the less you'll tolerate an elevated PSA. So, an average 40-year-old man, his PSA really shouldn't be over 2 or 3. Whereas a 70 or 80-year-old man, his PSA can be as high as 6 or 7 and still be normal. Why? Because as you get older, as I mentioned earlier, your prostate gets bigger. So, we don't use specific cutoffs, but it's important to understand that, in fact, PSA, there's no single right number that might be right for any individual. But in general, on a lab report, it'll say if your PSA is over 4, that's not normal, and that is what we typically use as the starting point. There are some other tests I won't talk about, but this last bullet is really important, which is how fast is the PSA doubling? So if your PSA goes from 1 to 2, 2 to 4, 4 to 8, and you can calculate how fast it's doubling. If it takes 2 years to double, that's much better than if it takes 2 months. So the doubling time is a very important additional factor in understanding kind of the underlying nature of the prostate cancer. And as I said, there's PSA, but there's also other blood and urine markers that help to basically tell a doctor if the PSA is abnormal or normal. Now, many men do not like the digital rectal exam, and here's an example of what the doctor's doing when he's examining your prostate. And I showed you where the prostate is. This is your bladder, this is your penis, obviously, and this is your bowel, your rectum. So he puts a gloved finger in, and he can feel the back third of your prostate. And that's what a digital exam has been like for since I was a young doctor. But I do not really do this exam very much anymore. Many urologists have felt the need not to do this test because if you look at it, it has a very low cancer detection rate. Most of the time, you cannot feel anything, and that's because if you look at it, you can't really feel the whole prostate. It's not like a breast exam where you can actually feel the entire breast, and so you might be more likely to feel a lump. This is a very, very difficult exam to be able to feel something. So you see these very low percentage of cancer detection rates from these different studies. Is digital rectal exam important once you have an elevated PSA? The answer is probably yes. But as a screening test, it probably has a little diagnostic value. Now, there were two very important studies that looked at screening, a PSA test as a screening test in Europe and in America. And these were published now about 15 years ago, 16 years ago. This is the European study on the left and the American study on the right. And you can see it was, uh, tens of thousands, hundreds of thousands of patients in both studies. And you can see the age of the men who were screened. And you can also see that not everyone, even though they went on a clinical trial, not everyone was screened. But I think the American study is particularly informative because 85% of the men who were assigned to get a PSA test did get it, 15% didn't. But actually, half the men who weren't supposed to get a PSA already got it. Why? Because PSA, by the time they did this American study, PLCO, PSA was widely available. I showed you that it's been available since the 1990s. So it's very hard to compare no PSA testing to 100% PSA testing. Instead, the American study, PLCO, was really a comparison of 85 versus 52%. You can see it would be much harder to prove. that a PSA test is valuable. Whereas in the European study, they didn't report it, but most of the men who were not assigned to screening did not get a test. And you can see it's either annual versus every 2 to 4 years, and this was the cutoff where a biopsy was indicated. Now, um, the conclusions of these studies were that uh, there was a survival benefit if you did PSA screening. It was a small one, but there was a benefit to PSA screening. The other thing that, as I mentioned, is when I say contamination, I mean that if you're really doing a test of PSA versus no PSA testing, you shouldn't give the men in the no PSA testing a chance to do PSA. Otherwise, you will never prove whether the PSA made a difference or not. And that makes the American study less valuable. The other thing we've learned is over time, screening becomes more valuable. So in other words, a PSA test in an 85-year-old with poor health may not be particularly valuable, but to a 50 or 55 or 60-year-old man who may live 20 years, the PSA test could absolutely find a cancer that is important to treat. And that's why you have to consider patient age, their other medical history, and whether or not they want to actually look for cancer. And then the other part is even if you find cancer, you don't have to treat everyone with prostate cancer. So this is the group, USPSTF, that's the screening group in the United States, the Preventative Services Task Force. And they gave this screening decision for men age 55 to 69. You can see it's a very long, overdrawn description. This is what primary care doctors are told. If you want to get a PSA test, you should basically discuss it with your doctor. And they gave it a grade of C, which obviously is not very encouraging. And you can see that for men over 70, they said don't do it. They gave it a D. And that is why Joe Biden stopped doing PSA testing at the age of 72, because his doctor was following this strict recommendation. I said this is to be updated soon. Unfortunately, when the current administration came in, they basically shut down this group, and we're still waiting for the new recommendations. But these were uniformly disliked by many cancer doctors, and I think the thing is that many primary care doctors still do follow these recommendations. So when they change them or update them, it will really change what we would do. Now, there are guidelines. This is from the American Urological Association for high-risk patients, and this is a strong recommendation. So black men in the United States, as I mentioned earlier, have a very high risk of developing prostate cancer. If you have a very strong family history, and here's a list of what that means. I'm not going to go through it all, but a strong family history of prostate cancer also means that you should get screened and that you should be screened as early as age 40 to 45. And if you have one of these genetic mutations, the most famous one, of course, is BRCA1 or 2. This is what Angelina Jolie had, that you should also be considered for screening. What's coming? Well, if you know women who know about mammograms know that MRI and ultrasound and imaging tests have become a big part of the way we kind of sort through breast cancer screening. So mammography has been around for a long time, but now we're even getting better with ultrasound and MRI. Well, it turns out prostate cancer MRI is also very, very useful. And there are more and more studies that suggest that depending on your PSA and MRI can kind of tell you whether you should move to the next step. And they actually did a study in the UK where they actually did PSA and MRI in all men. And in those settings, you were much more likely not only to find cancers that or suspicious prostates that you should biopsy, but also who you should leave alone. So MRI is really going to come more and more. You don't get any radiation from MRI. It's the problem with MRI as a screening test is that it's very expensive. And so we're not going to see everyone get an MRI, but you'll see MRI becomes an important part of the algorithm. So what's the summary? PSA screening, it remains controversial, but I say it's not only an option, but it's something that if you're in your 50s and 60s, you should definitely consider. And that's because you'll live longer if you screen and you find cancer. It also suggests that, if you follow men for 10, 15, 20, 25 years, that the benefit actually increases with time. Of course, you could be very unlucky and be a 50-year-old and get into a car accident, but we can't plan for that. We only know that if you screen a man in his 80s or 90s, you're less likely to benefit. So if you're going to do a screening test, you should really find men who are going to live 10 or more years and consider a PSA test. And these high risk individuals, genetic risk, strong family history, or black men should be offered screening in their 40s. I don't think Portuguese American men have any stronger risk than any other East European population. But if you have a genetic risk or a strong family history, or if there's some admixture of black race in your family, then those are people who should really be considering screening earlier in your 40s rather than your 50s or 60s. And then if you get to now, how do you know if you're going to live less than 10 years? Well, none of us really know. But let's say you're in your late 80s and you or you have multiple medical problems, you can stop doing PSA. The problem with the Joe Biden story is that he was 82, he was in his 70s, and he was otherwise pretty fit. So even though they were following the recommendations, if you're healthy enough that you think you're going to be around in 10 years, you probably shouldn't stop the screening tests. Okay, I'm going to talk a little bit about treatments now, and I'm going to first talk about localized prostate cancer, then advanced prostate cancer, and talk a little bit about imaging. What are the treatment options for localized prostate cancer? Well, um, you don't have to treat everyone. So there are men who are diagnosed with low risk prostate cancer for which we just survey them. And in fact, right now in the United States, about a third of men are not treated. They're biopsied, they're diagnosed, and the cancer turns out to be a low risk, low grade cancer that you can just survey. Surveillance may mean that they have to get a PSA test or get an MRI. They may get follow-up biopsies, but they don't get treated right away. Sometimes you'll hear it called watchful waiting, but it's really active. You have to, especially if the man is younger and healthier, you have to really make sure that the cancer doesn't change. This is a robot. It's a Da Vinci robot, and it looks like it's operating by itself, but it's not. There's a doctor on the side who controls those arms, and that's called a robot-assisted laparoscopic prostatectomy, or RALP. So, 98% of surgeries in the United States now are done with a robot. And that's because it helps the surgeon to really see where the cancer is, to remove it, and patients often get out of the hospital same day or the next day. It is really quite a big dramatic change, but you have to find surgeons who are actually experienced and skilled in using the robot. And radiation's gotten better too. This is a radiation treatment. It's an external treatment. It's also quite good. And I highlighted the biggest recent advance, which is stereotactic body radiotherapy. You can often treat prostate cancers with as few as 5 treatments now. And again, the accuracy of the radiation beams has gotten better and better. And there are some other treatments here. For the sake of time, I'm not going to talk about all of them. But we have a clinic at Yale, and other people have clinics where they talk about individualized treatment for a patient. So the patient will come in with a specific history, and they'll see a surgeon, they'll see a radiation doctor, they'll see a medical oncologist like me, and then we try to look at everything about their data and give them the best advice about how to move forward. Okay, let me talk a little bit about a really exciting new imaging test called PSMA PET. I showed you a picture of that earlier in the fake case that was Joe Biden. But here is what PSMA stands for. So it's not PSA, it's prostate-specific membrane antigen, but it is a prostate-specific protein. And you can see that it sits on the surface of the prostate cancer cell. In fact, it's highly expressed in prostate cancer cells, up to 1,000 times more than on a normal cell. And when you go on hormonal therapy, we see it even better. It is often expressed on the salivary glands and the lacrimal glands. That means your saliva or your tear ducts, and it's also seen in the kidneys. And so, because this protein is so prostate specific, what we found is that if we do a PET scan with PSMA, targeting PSMA, you can see here, just like that earlier picture I showed you, you see the salivary glands and the tear ducts, they light up. That's one of the non-specific, that's not cancer. You can see it's very symmetric, but all these dots are cancer. This area that's really dark is the kidneys, and this is the bladder. And that's because after you inject this PSMA agent, it gets sorted, filtered through the kidneys, and then it comes out in the bladder. Um, we've had another kind of PET scan for many years called FDG PET, and FDG stands for glucose. It's a type of radioactive glucose. And they use this scan for lung cancer and lymphoma and other cancers. And prostate cancer doesn't usually make FDG, but you can see in this patient, this is the same patient with two different scans. You can see that some of his cancer cells, which are red here, um, are only making FDG, and the blue ones, which are making the prostate cancer cells, are blue. And sometimes they correlate exactly, and sometimes they don't. But it's really the PSMA PET that has transformed the way we look for prostate cancer. And you can see, as I'll talk about in a minute, if you can see these spots, you can actually target them with a new type of treatment called lutetium 177 PSMA. So let me talk about some of the new therapies for metastatic disease that are keeping men alive for years. Metastatic disease means cancer that has spread. And when I started in this field 25 years ago, there was not a single treatment that kept a man alive longer if they stopped responding to hormone treatments. That is, we could use hormone treatments. We call it androgen deprivation. That's because these cancers need male hormone to grow and survive. But if you after you stop the male hormone, what you see here is the cancers tend to grow, and about 20 years ago we had chemotherapy, this orange, and we could make it go back, but unfortunately the cancer could still grow, and patients would still die. And the average time, if you had metastatic disease, which is cancer that recurred and went to the bones, for example, was only a year and a half. But now we actually have all these therapies. I'm not going to talk about them all, but you see they're color coded, and there's so many new treatments now for prostate cancer, which has really transformed the field. But part of it is that you see, if you look at a cancer, we tend to think that cancer is homogeneous, that they're all the same. But in fact, the truth is that they're really a mixture of cells. Some of them are very sensitive to ADT, which is hormonal therapy, but some of them are not. And if you use just ADT, what you see is that you kill some of the cancer cells, in this case, the blue ones, but then you select out more of the red ones, which are resistant, and then you create other resistant ones that weren't even there before, like the green ones. Whereas if you do combination therapy, you may be able to target and kill more of the cancer cells, so that these light brown cells are really more like normal prostate tissue that is not cancer related. So this concept of combination therapy in metastatic prostate cancer has become a new standard, and you can see that not only do we give androgen deprivation therapy, but we actually also can give these additional treatments, including chemotherapy, but also including these hormone medications. And in the last decade or so, you can see that there's all these clinical trials. In fact, 11 randomized clinical trials. This is what Susie does for a living is she gets people onto clinical trials. And this is why we do clinical trials. These clinical trials that are really occur at places like Yale and around the world showed that your survival by using a second or third drug, you can actually keep men alive longer, anywhere from 20 to 40% if you do two drugs, doublets, or triplets, including chemotherapy. That's a huge difference. These men are living years longer. And I can tell you from my own experience, men who used to, unfortunately die of metastatic disease in 1 or 2 years are now living, 3, 4, 5, 10 years, sometimes longer. So the message here is hormonal therapy alone, or ADT alone, androgen deprivation therapy alone, is what we used to use. Now we can combine it with chemo or some of these hormone pills, which we call ARPIs, or we can even do triplet therapy where we combine chemo plus these hormone pills. But we shouldn't be giving just one medicine anymore, and we shouldn't be giving chemo alone. We should give either triplets or we should give doublets. Susie said that I'm the director of precision medicine for the Yale Cancer Center, and what that means is that if you actually sequence these tumors and you find these different molecular findings, I mentioned BRCA1 and 2. There are drugs that specifically can target cancers that express those genes, and what we're seeing is that even though BRCA stands for breast cancer, about a quarter of all men with advanced prostate cancer, what we call MCRPC, these are cancers that have become resistant to hormone treatments, about a quarter of them actually have one of these, what we call DNA damage repair mutations, or DDR mutations. And half of those are the BRCA mutations. And the reason this is important is that there are drugs that can target this BRCA and all these other genes. In fact, about half of these men inherit them from their mother or father. So if you come in with this very advanced castration-resistant prostate cancer, we are able to test, and if you are positive, these men do respond to these treatments. The problem is a lot of men never get tested, and this is a real problem in the United States that many men do not ever get tested for these mutations. And then the last part I'm going to t finish on is I mentioned this earlier, this LU-177 or lutetium-177 PSMA. This is a New England Journal paper that shows a little bit about how it works. So remember, I told you that the PET scan shows these spots, but now we can actually not just show it, but we can send in a radioactive particle, Lu-177, that goes in and then kills the cancer cell. So the concept here is you treat what you see and you see what you treat. That is, you can see it now, and then you can deliver a particle that goes in and destroys the cancer cell. And these are called Kaplan-Meier curves. You don't need to read these all day long to understand, but these are huge clinical trials, large clinical trials, where you can see that the overall survival, or OS, was significantly better. Now, to somebody who doesn't have advanced cancer, that looks like a small difference, but it was a 40% improvement in overall survival if you receive this drug. And I can tell you, I use this in clinic. We just started doing this treatment in Greenwich, and we've been doing it in New Haven. Patients feel better, their cancers shrink away, and it's quite a significant improvement in what we had before. And you can see it here again. These are waterfall plots. Each of these blue lines going down is a single patient, and you can see that this is the LU-177, and this is SOC is standard of care. So if you just give a standard of care drug, you get a very small response rate with PSA, but if you give this drug, you see the majority of patients will have some benefit, and about half will have a confirmed decrease in PSA. So one of the things we're trying to do is to try to take the generic group of patients who are diagnosed with cancer, whether they're men with prostate cancer, women with breast cancer, and to look at their whole personal and cancer profile, not just some of the things I mentioned today, like family history, but also their microbiome, which is what do they eat, and their ancestry, and their genome, and their gender and age, and try to put them into buckets. You notice there are three different colors here, green, yellow, and blue. In theory, there could be 1,000 colors, but we don't have enough drugs to customize to 1,000 different ways of treating prostate cancer. But we know that there may be a dozen, and that some people might benefit from one treatment versus another. So I'm gonna pause there and stop sharing because we'll have some time for questions. But thank you very much for your attention.
That was excellent, Dr. O. Thank you so much. Lots of things that I didn't even know about, but I think what you touched upon that was most um, impressive for me coming from Semaphore is the precision medicine piece, right? Not painting a broad brush with people's treatments. So I know if it was like my dad, obviously, and if he had prostate cancer, then I would want him to get the genetic testing so he gets precisely the medication that he will respond to, for example. So that's been something that's been on the rise for more and more different diseases. So it's very reassuring.
Yeah, yeah, I showed that one slide. I went through it very quickly, but basically, about a third of all men and women with cancer have a targeted treatment that only works if they have that genetic mutation. We want to get that to two-thirds or more, but a few years ago, that was zero. We never did molecular testing. So, as you remember from Semaphore and from all these genetic testing companies, we're able to more precisely bucket people in whether they're green, yellow, blue, or whether there's more categories, but that people who would get the drug that will work only for them. If it doesn't work, then why get a treatment? Because they have side effects and they also have, they're very expensive. So we're trying to be smarter about what works for whom.
Right. And you would think that the insurance companies would be all in because why have them go through three different treatments and they may not work? Go directly into the one that will work, right? So,
Exactly. Exactly.
if anyone has any questions, you can either write it in the chat or I guess maybe if you can raise your hand, I can allow you to speak by pressing a button. So in the meantime, until somebody decides of a question, I do have a couple that we came up with ahead of time. You did touch upon um, at what age do you recommend someone screen? You touched upon, even though the 2018 guidelines were 55 to 69, I believe, You said 50s and 60s, so maybe around 50ish. Sure. Okay. Okay.
Yeah, I think the average man should probably get their first PSA around the age of 50. That means if many men already have, but I meet people all the time. They're 55, 57, they've never had a PSA test. You know, men are not the best. Well, let's face it. I include that in myself in this group. They don't see an OB. They don't get routine preventive care. If they've had a medical issue, they might see a doctor. Now it is changing. I will say in my career, I've seen men become better at taking care of themselves, and there are more tests and more things that can protect your heart and so on. But most men should get at least one PSA at age 50, and they should probably get it every 1 to 2 years thereafter. Now,
Okay.
if you have a very strong family history, if you're black, if you have one of those genes, then you should definitely start doing it earlier, like in your 40s. Most people won't know if they have those genetic changes. Most people know if they're black or white or Asian, but but people do know their family histories, and that's something that you can find out about. I also find, Susie, that most people don't ask about it. You know, what did grandpa die of? You know, back then, as you know, they didn't talk about it very much, right? They didn't
Right.
talk about it. It's always worthwhile, since this is a cancer that is strongly determined by not just age, but by family history, that worth asking about.
And what about symptoms? Are there like any signs or symptoms that someone may be experiencing that they should be a red flag?
Yeah, that's a really good question. th- there's two problems that happen in the prostate as men get older. One is that the prostate gets bigger. That's called BPH, or benign prostatic hypertrophy. And the second is that you can develop prostate cancer. They both happen in the same men, in the same age group and in men. And they can happen in the same man. Just because you have an enlarged prostate doesn't mean you have cancer, and just because you have cancer doesn't mean you have an enlarged prostate. Uh, the reason I bring this up is that the most common symptom is no symptom at all. It's usually just a rise in PSA. But the second most common symptom of prostate cancer is urinary symptoms, more urinary frequency, waking up at night to pee, those kinds of symptoms. So difficulty emptying your bladder. So the majority of men who have those symptoms, because they're very common, will not have cancer. But you see how common prostate cancer is. So it's not uncommon for a man to have, who's having difficulty urinating, to also have both an enlarged prostate and prostate cancer. That's not uncommon. But the vast majority, to answer that question, actually have no symptoms. And, you know, I saw a man in my practice a few days ago, and his cancer is quite advanced. And the way it was found was a blood test. And, and he just can't believe it. He's like, I don't understand how it could have spread without me feeling anything. And that is why screening is not about waiting until you feel a symptom. One reason why pancreas cancer, for example, has such bad outcomes is you can actually have a really big tumor in your abdomen without knowing that you have it. That's bad. The reason we can treat skin cancers early is we can see it on our skin, right? But inside your body, you can't see it, and that's the case for most prostate cancers. Many men don't have any symptoms at all.
Okay. Some people are coming in with some comments here. Karen says amazing information. Alexis is saying this was incredibly interesting and informative. Thank you for sharing your knowledge with us, Dr. O. There's a question. Is this the one that we just went over? Are there any
Yep.
signs or symptoms
Yep.
someone may experience? Okay, so that's
Yeah.
warning signs that we just went over that one.
Yep.
And then we have, if you have time, we're
Sure.
still good on time.
Yeah.
Okay. This has to do with your exact slides. So this way you know that we were actually reading them. Um, it did say that incidence was rising since 2014. Why is that?
Yeah, let me show that slide again so we
New
can.
cases rising since 2014.
Yeah. So it's a really good question. Let me just show that again so people can see it. Um, because it is something that we've been debating exactly why this is happening. So let me just pull it up here. Okay. So okay. You see that slide?
Yes.
Okay. So the guidelines that I showed you about PSA screening, They came out about a decade ago. And when they said don't screen any men over the age of 70, and when they said if you're 55 to 69, talk to your doctor about it, it kind of shut down PSA screening. So there's a belief that this rise in prostate cancer incidence at least is partially related to the fact
Okay.
that men were told don't bother with a PSA test.
Okay. So that's why the changes in 2018 to start again.
Yes,
Um,
yeah. So the hope is, well, these guidelines here are from 2018, right? So it's going to be, that was a long time ago. That was 7 years ago. So it's going to be updated. We're 100% sure. But what we don't know yet is to what extent they'll change the recommendation to include, for example, younger men, not 55, but maybe 50-year-olds. American Cancer Society recommends men as early as 45 to get their first PSA test,
okay.
just average risk. But I think if you get your first PSA at 50, I think that's a reasonable compromise right now, unless you have a strong family history.
Right. Makes sense. And here's another great question. It's an observation by looking at your slides. It seems reproductive cancers such as prostate cancer and breast cancer have continued to be leading cancers since 1975. Why is that?
It's a good question. I do think it's related to diet and lifestyle. Since the 1970s, um, you know, I just turned 60 a few about less than a year ago, and when I was a kid, I don't remember supermarket shelves being the way they are now, and we have access to a lot more calories, a lot more food. I know that we couldn't afford meat when I was growing up. My dad would get the one steak in the family. I have five kids in my family, so then we would get to, get the leftovers. So, it was a time when nobody ate out back then. It was very rare to go out to eat. It was a special occasion, a graduation or something. So um, I think our diets are probably affecting it, but they don't affect all cancers equally. Like diet may not affect lung cancer. Lung cancer is probably much more related to cigarette smoking, although there's now a group of people who are getting lung cancer, younger women who are not smokers. Remember Dana Reeve, Christopher Reeve's spouse, and we're seeing more trends that are not related to certain environmental impacts. But I think breast and prostate cancer are metabolic cancers, and that means that, for example, as certain factors continue to change, like obesity or the way we eat or the kinds of foods we eat, we may continue to see a rise. What's interesting that we don't know the answer to yet is will these medicines like GLP-1s, like the Ozempics of the world or Zepbounds, will they start to change the cancer risk into the future? And it's an interesting question. I don't think anyone really knows the answer yet. There
Right.
there are data, epidemiologic data that people who are on these medicines may actually have a decreased cancer risk over time, particularly for these metabolic cancers. So it'll more to come on that, but we don't know quite yet.
Maybe you should start that clinical trial and collect some data.
Yeah, I think so.
I mean, it's lowering people's cholesterol levels when they lose weight, right? So maybe it is having a metabolic effect on cancer cells.
Well, we've had statins for a long time, so it may not be just through that. It's not clear. There's some evidence that these GLP-1 drugs might actually decrease inflammation, and we know there's good inflammation and bad inflammation, but a lot of it's still speculative right now. We don't know the true answer. So what can you do right now? Eat healthy, minimize red meat, um, exercise, all the things we know. I always tell people it's do what's good for your heart, and your prostate will follow. So it's but in the end, I think um, you know, like family history is really sometimes you can't outrun your genetics. Sometimes you just can't. So a lot of times these are unknowns about the different risk factors in each family member, in each person.
You know, you mentioned red meat, and meanwhile, my husband's downstairs grilling steaks tonight. So,
Well, I don't want to spoil your dinner
yeah.
tonight, Susie, but
Yeah.
once in a while it's fine. I mean, listen, it's you can't live your life
Right.
afraid in fear. But I
Exactly.
think, again, I'll harken back to when I was a kid. It was not uncommon for people to have a big sausage egg breakfast every morning. It's like that was a hearty breakfast. And that's not a great idea. I think everything
Yeah.
in moderation. And I think again, for an average risk person, like you always have to ask yourself, what could I do to my lifestyle and diet? And it doesn't work if you say, I'm going to go, I'm going to freeze out all red meat. That doesn't work. But you can ask yourself, can I, cut back by 50%, or have fish more often, or increase the amount of vegetables in my diet.
Right. Okay. I do have one more question. Oh, and Tiffany says such a great, thorough presentation. Thank you for the information you provided.
Thank you.
We don't want to keep you forever. We could easily do that, but I think this question merits discussing. Would you recommend genetic biomarker testing if one has had family members with different types of cancers, not prostate cancers per se, but different types of cancers? For example, um, let's say a family member who gets breast cancer under the age of 50, and then another first line relative gets another cancer between 50s and 60s. Like, what would you recommend for that person?
Well, when I see a patient with prostate cancer, remember, I'm seeing him, he already has cancer, and I'm asking their family history. I don't ask just about prostate cancer. I ask them if they have a history of breast cancer in their family, or ovarian cancer, or pancreas cancer, because all of those cancers are linked to the BRCA genes. So there are other family familial syndromes of cancer too. So without being able to go into it at length, what are the red flags? Well, those four cancers are often linked together, and that's the most common um, uh, genetic abnormality that leads to cancer, the BRCA genes. But the others are really early onset cancer, as you said, Susie. If somebody presents in your family with a history of early cancer, it's always, especially if it's a common cancer that normally occurs later, like breast or prostate. Those are cancers where I think it will often trigger a genetic test, what
Mhm.
we call a germline test, meaning we can check your blood or saliva, and we can look for genes that are known to increase risk of those cancers in early ages. So it is an important thing. The more you know about your family history, the more you can protect yourself against,
Mhm.
kind of the risk of developing something, even early in your life. There is a scary trend, which is something called early onset cancers. This is not affecting prostate as much as breast and colorectal, but there are young women getting breast cancer now in their 30s and 40s, may be tied to diet and lifestyle, maybe alcohol. Sorry if you're going to have a glass of wine with your steaks, but alcohol may increase risk of some cancers, and colon cancer. We're seeing earlier amounts of colon cancer in earlier ages, partly probably from processed foods, like um, you know, foods have changed. You go to Portugal, and you go to they buy the food that they're going to eat that day. They go to the market, that's the way people used to eat. But even in places like Portugal and Italy and the old places, they now have big supermarkets. People are busy, they're working, they get prepared foods. It's not the same. But we all have to live our lives, and I'd say the key is to just think of common sense types of interventions, which is to eat as much, natural food as possible, as little processed food as possible. Given that might be one of the underlying reasons for the increase in colon cancer rate in young people.
Yeah, the Western Europeans love their, cured meats and all that good stuff, but I
Yeah.
agree, all in moderation. So does anyone else have any questions for Dr. O before we sign off? I do want to let everyone know, when I stop this webinar, there will be a survey at the end. Please try your best to fill it out. It helps us gauge how well we did, whether the topics we're bringing you are timely and relevant. And it also asks for you to contribute your thoughts on future topics. And at the end of July, we have a colleague of Tiffany's speaking on mental health. That will be sometime, I think, the last week of July. So we will start advertising that in the next couple weeks. Hope you can join us for that one as well. We'll try and have one a month. I don't see any more questions, so I think that's it. But Dr. O, again, thank you so much for your time. I know you're a busy person. I wish you a happy Father's Day if you celebrate.
Yes. Thank you, Susie. Thank you all for the invitation. Hope everyone has a wonderful weekend. Take care.
You too.
Bye bye.